Hello, I'm Kieran Anderson, Group Publisher here at Applied Radiology, and I am delighted to be joined by Bill Faulkner today to review the results of our 2025 MRI Safety Survey. Bill is an MRI safety educator and consultant. He's a founding member of the ABMRS and the president of Faulkner and Associates. His extensive experience in MR imaging will add significant value to this discussion today about the importance of MRI safety and the mitigation of MRI safety incidents. Bill, thanks so much for joining me here today. Looking forward to chatting with you.
Thanks, Kieran. It's always a pleasure to be with you. I appreciate the opportunity to look at this survey and discuss the results with you.
That's fantastic. As I said, each year we conduct this safety survey, which is shared with really several thousands of our subscribers who really play a key role in overseeing MRI safety and the protocols and the procedures in their facilities. And my real hope today is that you can provide some further insights to the results and what this really means to the MR imaging community, given the number of the incidents we've seen over the last few years and certainly some recently. So, with that, Bill, I'd love to get right into the survey and have you kind of take us through it and provide some insight as we move along. How does that sound?
Sounds great. What I noticed, first off, I'd like to kind of give you some idea of who responded. We had 302 responses. Of the centers that responded, approximately 36% were academic medical centers. Approximately 30% were independent imaging centers. 25% were of an IDN type. And then approximately 9% were governmental, federal, such as the VA. Of the people that responded, now some of these could have multiple roles, but approximately 59% of those responding were MRI technologists. 17% said they were MRSO. 15% were radiologists and fellows. A little over 4% were physicists. 12% said they were radiology administration. And now, with regard to what we saw in the survey, the first question in the survey was, in the case of a safety question or concern, who has the responsibility for determining if a patient can safely undergo an MRI scan? I've seen this change over the years, where in the past, the radiologist, supervising radiologist, which in this survey was 52%. Seem to recall that being less in the past. So this is increasing, and that's actually who should be responsible for that. What concerns me is that, again, let me kind of couch this here a little bit. If the MR medical director has policies that state the MR safety officer or the technologist can clear a patient, assuming they meet all the conditions of use of a implant or device, that's not an uncommon, nor is it an unreasonable policy or procedure. It's just that when there is a concern of either being able to identify the device or a concern about being able to meet the conditions of use, then that's going to need a medical doctor to make that decision. That's a risk-benefit decision. Technologists do not determine safety. Technologists implement safety. One of the things that I like to talk about in this risk-benefit decision is this can often be and should be a team-like approach. It's not uncommon in facilities for a technologist to have a little more in-depth knowledge with regard to the risk associated with the various energies in MRI, more so than the radiologist. However, the radiologist has the medical background and training to assess benefits to the patient. So again, it's kind of a teamwork in this risk-benefit scenario, but the bottom line is, as a technologist in the United States, and this is another thing we need to make clear, this can vary in other countries, actually, but in the United States, I, as a technologist, am not licensed to practice medicine, and therefore I practice under the direction and supervision of a radiologist. And so that is concerning to me that 28% approximately answered the MRI technologist had the responsibility for determining if a patient could safely undergo a scan. 17% was the MR safety officer. In my experience, the majority of MR safety officers by far are technologists. So it seems like there's still this tendency to push this decision toward a technologist. And in the US, that is just absolutely not advisable. Again, other countries have different requirements. The other one was, does your facility have a designated MR medical director? This one I definitely have seen increase over the years. In this particular survey, nearly 60% said yes. However, almost 31% said no. Some were unaware. But that one I do believe is increasing, and that's very promising. The next one was, does your MRI facility have an MR safety officer, MRSO, with advanced MR safety training? This one I also believe has increased over the years, but still, nearly 39% do not. And if the MR safety officer is going to be involved in the safety management, then I think advanced safety training is extremely appropriate. The ARRT exam for an MRI technologist has 200 scored questions on the exam. And of those 200 scored questions, 21, according to their content specifications, are MRI safety related. That's slightly more than 10%. It's only 10%. That relate directly to safety. So I think it's very critical to have advanced safety training, because whether the technologist is an MR safety officer or not, having additional training in the details of MR safety is extremely important, because that truly is the last line of defense from an MR safety standpoint. And to that same point, yeah, the MRI technologist is the last line of defense, but if the MRI technologist is your only line of defense, then that can be problematic. So I still think there's work to be done here in having people understand the need for advanced safety training, because MRI is not getting simpler, it's becoming more complex. And if you look at the technology change where it becomes more automated, okay, you think, well, that's, then we don't need somebody with extensive training here, but you still got the safety issues with it. And I think as automation improves, as AI increases the speed of data acquisition, then you've got to be careful that you don't let the safety requirements or safety management kind of get lost in this push for increased throughput. The next one was, does your MRI facility practice an annual mock code to include the emergent removal of a patient from an MRI system? Here, 51% say no. You can't run an emergency in a scan room, and if your department is set up as it should be, where zones 3 and 4 have secured access, and you have that safety isolation security there, if your table undocks so that one technologist can quickly get a patient out of the scan room, but a lot don't. And if your staffing is such that you have single technologists, if you can't get that patient out of the room in the event of an emergency, this is very problematic. If the patient, for example, had a cardiac arrest, I mean, the first thing you're going to need to do is you're going to have to call a code, and then you've got to get the patient out of the room. But you better have the patient out of the room by the time the cavalry arrives, because otherwise you're going to have a major safety issue. Everything works well until it doesn't, as I heard someone say one time. The next one says, at your facility, do all the MRI trained radiologists undergo annual safety training? And in fact, I find the next two kind of interesting, right? Because, the first one asks about all the MRI trained radiologists undergoing annual safety training. These are the people that are making the risk benefit decisions, by the way. And if you're an MR medical director, you're, managing this whole safety program. So when it asked about the radiologist, only 40% said yes, and almost 30% and 26%. So a majority is either no or I don't know. And, I found a lot of technologists don't know what kind of training, if any, that the radiologists undergo annually. But if it's interesting, if you look at the next one, at your facility, do all of the MRI trained technologists undergo annual safety training? 75% yes. Okay. That's great, but these people, again, are only a part of the safety management. And I go back to what I said before. I think this kind of points to scenarios where everyone's relying on the MRI technologist to be that line of defense to actually take care of this. Well, they're not there all the time. So again, I think safety training is a system-wide thing for MRI departments. And I think we can learn something from this. I think we still need more safety training for the MR radiologists. They're part of the safety management. And then the next one was at your facility, who's responsible to ensure the safe practice guidelines are established, maintained, and current. The ACR clearly says the MR medical director is that person. In this survey, you can see that the results are pretty much all over the place. And I think it's important to know that you have to have an MR medical director who sets the tone of your MR safety program, because again, this is a medical procedure. And so you have to have a radiologist, you have to have a medical director, MD, heading up this safety practices. So again, I think there's probably some room for improvement here. Then who is responsible to see that the safety practices are adhered to at all times? And in this one, the MRI technologist, MR safety officer, radiology administrator, they tend to be the top ones. And I think if you look at the ACR guidance document and other documents that talk about management of MR safety, ensuring that the policies are adhered to at all times, I think this is the perfect top tier responsibility, if you will, for the MR safety officer. And then just a few more little questions here we're following up about which organization accredits your facility. And 21% are not, 22% are not accredited. It's interesting that 57% are ACR accredited, but then when you look at some of the guidelines that the ACR recommends, obviously not all of the guidelines are followed. The next one, does anyone other than MR personnel have free access to Zone 3? What bothers me is that 47% said yes. And that's clearly a safety concern. If other than MR personnel have access to your Zone 3, that just means that's an accident waiting to happen, in my opinion. And then lastly, some questions about implants. Question, does your facility scan patients with MR conditional active implants, such as cardiac pacemakers, ICDs, and that? So these are conditional items. Nearly 76% say yes, 21% say no, but then again, keep in mind that these implants and devices often have requirements that maybe the facilities feel that they can't meet, or in the case of active implants, it's really important to adhere relatively closely to the conditions of use with very few exceptions. And so some facilities may possibly have MR systems outside of the tested conditions of use, field strength, for example, and that could understandably prevent them from imaging patients with certain active implants. And then a question about, do you scan unlabeled active implants? In other words, legacy pacemakers that are not MRI conditional. Large majority, 79% say no, and a small portion, 14% say yes. And this is really important because even the Heart Rhythm Society, which the ACR recommends following their guidelines, do stress that you have to have a very comprehensive program in place to handle that. And then, does your facility scan patients with MR conditional passive implants, which may be considered off-label? In other words, coronary artery stents on a vertical field magnet. Nothing's tested on a vertical field magnet. But Dr. Frank Shellock has several articles on this, and there's several things that have been in the peer-reviewed journals that really show that the risk for scanning patients with passive implants on other field strengths, such as 1.5 or on lower field strengths, really poses little to no problems. This is where it's important to have this understanding of MR safety. Conditions of use, remind everybody, conditions of use state the limits of testing, not the limits of safety. And so a passive implant outside conditions of use rarely present any type of problems, but yet 47% will not, and 38% will, in fact. And then lastly, next lastly, I guess, how often do you review or update your MR policies? 28.5% as required, 51% annually. I think an annual review is definitely recommended, whether one updates them or not. But I do think it's also important to have an active MR safety committee, not one that's part of the radiation safety committee, but an active specific MRI safety committee. And so they can kind of keep an ongoing review, if you will, of the MR safety practices. And so I think that's pretty much the view of the survey. I don't know if you have any questions or comments related to that.
Well, I do, Bill, and thank you very much for taking the time to kind of review those survey results with us here at Applied Radiology, just sort of adding your own experience and insights, and quite frankly, even some of your own concerns as it relates to some of the responses. As someone deeply involved in MRI safety education, and governance, something you've been involved with for a long time, how do you view the results in the broader context of MRI safety, where it is today, as you think about what we just reviewed in those survey results?
Well, I think that first off, you're looking any type of survey, you have to consider, well, who's answering the survey. And so I think, we have people who are focused on MR safety, so they have this kind of in their forefront. So that's the audience. So like I said, I do see some improvements in more involvement in MR medical director and radiologist, but where I do see, again, kind of a lack of movement or improvement is in that planning for the worst case scenario, code and MRI, emergent patient removal, and education kind of across the board for radiologists. And then also the apparent still lack of controlled access when you have that many percentage of your people that have free access into zone 3 against the recommendations from the ACR for decades, actually.
That's certainly a concern. Do you think these results suggest progress, stagnation, or even, uneven adoption of best practices? Because like listening to you, while there was improvement in some areas, there's certainly some other areas where there wasn't. And it seems that it's either stayed the same or even potentially gotten worse, particularly when you think about the number of folks who, thought MRI techs, were the front line. What are your thoughts there?
Well, yeah, I do. I do still see a little bit of stagnation, and I think one of the things that that causes that is if a facility believes that their practices are working. Right? If I haven't had any major instance or not aware of it, this is, then everything must be fine. Again, it works well until it doesn't. And as time goes on, there was several articles I have read, including a book written by a sociologist called Diane Vaughn. It's called Normalization. She introduced this concept of normalization of deviation. And I definitely see this in facilities where unsafe practices go on for so long that they become ingrained into the way things are done, and everybody sees it as safe. It's kind of like if nothing bad's happened, then it must be okay. That's really kind of a risky scenario to look at. It's that kind of thing where the longer you've got standards, and then you start to deviate from those standards, and nothing bad happens, no immediate detrimental result. And so your deviation gets wider and wider and wider and normalized.
So true. As I'm looking here at listening to you, I'm thinking about how the survey attempted to reinforce really the importance of standardized safety protocols in MRI. I'm wondering from your perspective, what is the value of adhering to those established guidance, that say comes from, the ACR MRI safety guidance document? Are these clearly defining who is responsible for safety within the MRI safety environment? Like, what are your thoughts, your perspective there?
Well, the ACR has always said that this document should be used as a template. One size doesn't necessarily fit all. And not adhering to everything within the document doesn't mean you have bad practices. Maybe it just doesn't apply to you. I think the practices should be specific to facilities. Some facilities are kind of limited in their design. Maybe they've got an MRI system that's been in place for 20 years. Their setup is not optimal. So they can, look at their practices and try to make it as minimizing the risk as much as possible. Maybe they can't adhere word for word to the ACR documents, but I don't think that's the point of the ACR documents. I think it's, again, to give us some ideas, some recommendations, standards we can look to. But to do that, you have to have an organized safety management practice. You need a MR medical director, knowledgeable, involved medical director, not somebody whose name's on a piece of paper and it rotates out every year because, okay, whose turn in the barrel is it this year? That's not the way to approach it. You need an active, involved MR medical director. You need a named MR safety officer. I think depending on the size of the facility, you need multiple named MR safety officers to do the boots on the ground. You need an outside consultant, possibly MR safety expert, depending again on what type of facility you have. All this needs to be in place, and then you can tailor your practices to the facility. Okay, one of the things I see that's really problematic is that to satisfy Joint Commission, okay, administrative people will literally go through the ACR manual, cut and paste, and that becomes our policies. And then what I find out when I go through there is they're not actually following it. But Joint Commission's happy because they've checked a box. But then when it comes to the actual practices, they don't do it. Every facility I've ever seen has got a policy that says we change patients out of street clothes. You find out that, well, not everybody does that. That's that normalization of deviation, right? Well, not had any problems with it, so I'm not gonna worry with it until
Right.
something happens. And then when something happens, then all of a sudden they look, oh, what went wrong? What went wrong? We got a policy. Well, you've got no cohesive adherence to the policy. So relying on just ACR policies to be your policy is not really any good if it doesn't really match your facility and then your people don't follow it.
When you think about what you just went through in the survey findings with us, were there any responses that stood out to you, either particularly encouraging or particularly concerning from an educational and competency standpoint? It seemed to me that the data suggests a need for sort of more structured or role-specific MRI safety training within these facilities.
I do agree. I think facilities, oftentimes when they look for where can we find safety training, well, where can I find it and where can I find it the cheapest, right? How can I get it done? And I've seen sites utilizing, decent safety training that's available online, but when you watch it, only a small portion of it actually pertains to what they do or their practices or how they function. So it really needs to be tailored to the practice so that it is meaningful. Education is useless unless it's meaningful and can be applied.
So with that said, you've been so closely involved with the ABMRS over the years and the development, quite frankly, of formal MRI safety credentials. How do you think these survey results reinforce the need for advanced certification?
Well, I think to advance MRI safety, standardization, using standards and safety standards, and that's part of it, but credentialing of individuals helps push the whole ship toward improvements in actual valid improvements in your MRI safety practices. You take a look at credentialing in any medical field. You look for a doctor that's credentialed in that specialty because that credentialing tells you that they have at least had additional education in this area of specialty. So to go through and obtain a credential of an MR safety officer, MR medical director, or MR safety expert requires additional specialized education and skill and search for knowledge, which only improves the quality of the actual performance or maintaining your MR safety practices. Credentialing is such a large part of what we do in the world. I mean, think about it. You look for somebody that's credentialed in their field. And as I said, I mean, nothing against the ARRT's exam and for an MRI technologist, but 20% safety. Whereas if you sit for a credential through the American Board of Magnetic Resonance Safety, it's just safety. That's all it is. If a question doesn't relate to safety, we don't put it on the exam. It's a pure safety related credential.
Is there anything new going on over at the ABRS when you think about the credentialing that you're offering?
Yes, with was not necessarily for technologists per se, but with the advent of and explosion and spread of remote scanning, the technologist is removed from the environment. The technologist is remote. So there are certain things that the technologist, if they're on site, can manage, right? But if the technologist is off-site and maybe not even logged into the center, they can't manage it, right? They can't do anything 300 miles away. So it's created a divided liability. You now have someone on site who's directly responsible for the exposure to people and the control of the environment, exposure to the main magnetic field, cryogen, maintain monitoring the cryogens, screening the patients, making sure we've got all this information so that the remote technologist can proceed with the scan. Now, the remote technologist is responsible for applying the radio frequency, applying the time varying gradient magnetic fields. The remote technologist has nothing to do with the static field because they're not the ones exposing them to that static field. So basically, in the case of remote scanning, whoever that individual is on site managing the patient, from the on-site standpoint, that individual, if you think about it, has to know everything an MRI tech has to know, except how to scan. Not the technique, the protocol, the SAR, the B1 plus RMS, all that has to do with the energies applied during scanning, which the remote technologist still does. And so there's that responsibility because they cannot, just because they're, contracted out, you can't contract away your liability. The center still has to maintain responsibility for that. So this person, whoever this person is responsible for communicating with the patient, things having to do with the static field. Everything a technologist knows, they have to know because the tech's not there, right? So these positions have various names. Some people call them tech aides, some people call them tech assistants, but again, the tech's actually off-site, so it's kind of hard to be an assistant to somebody who's actually not there. They would be responsible for seeing the patient was dressed, patting the patient appropriately, positioning the patient, all that kind of stuff. And so, whether they call them a tech aide or assistant, the ART has come up with a new registry. They believe they call it an imaging assistant. And again, they're going to test a variety of things, some of which is safety, some of which is, patient care, rightly so. And so just like an MRI technologist can undergo additional credentialing and safety as an MRSO, we think it's important that these people who are going to be on the local side have a credential that they can undergo relating to MRI safety. And this position took a while to come up with a name for it, but we came up with the title of MR Safety Tech. And again, it's a credential strictly related to MRI safety. And testing should be live by the end of February. And would be administered through Prometric testing centers, just like the MRSO, MRMD, MRSC. But it is that fourth credential for this new role that people are performing. And again, that role has liability. That role has responsibility. And so I think it's important. You don't have to be, you can be an MRI technologist, but not credentialed in safety. You can be a radiologist, not credentialed in safety. You can be an imaging assistant, not credentialed in safety. But I think it's a good idea to be credentialed because, like I said, that promotes quality, safety.
As we start wrapping up here, because this has been, phenomenal conversation. You've provided a lot of, remarkable insight into not only what we heard from the survey, but, really what's happening in sort of real world facilities, particularly with new technology like the remote scanning. I'm curious to know, sort of in your closing thoughts, like how can organizations sort of future proof their MRI safety programs? I mean, certainly, yes, they can, send individuals for credentialing and things of that nature, but like, any sort of take-home points, wrap-up thoughts here that you would, share?
Well, I think if I could try to summarize what all we've talked about, standardization and credentialing go together. But I also think it's important that the policies and the procedures are specific to the facility, that everyone's adhering to those policies and procedures, and that everyone has this mindset of safety and not look at it as just checking boxes. I think, administrative and management people can get involved as well and just don't rely on the MRI tech to take care of it. Well, the MRI will handle that, right? In the past, historically, and in a lot of places still today, MRI safety is assumed. We're also victims of our own marketing. MRI is safe, and all that kind of stuff. Well, it is when used appropriately, but again, you can't assume MRI safety. You always have human error, but your policies and procedures and your practices should look to minimizing the opportunity for human error, which means oftentimes multiple layers of safety. And I think that's, an approach people should start looking at going forward.
Well, I think that is some really good advice, Bill. Some great sort of take-home points for those listening in here today. I should add that, certainly, you and your colleagues at Faulkner and Associates offer opportunities and services to come into facilities and to provide safety reviews and things of that nature. So, that is, it's wonderful that you guys do that, Bill. It's been great talking to you today. Thank you so much for joining me here at Applied Radiology to talk about this.
Well, thank you, Kieran. It's always a pleasure.
All right. Thanks again.
Take care.